Last presentation by Dr. Mridula.
Thank you,
Guptha
Sai.
ring 4.
Thank you, Sai. My topic is Guptha ring in small pupil. So I'll just straight away go to the case. It was an angle closure glaucoma with a post-PI, very shallow anterior chamber, and with a 26.5 diopters of intraocular lens power. So this is how I introduce the Guptha ring. As the ring is introduced, I get the first scroll onto the tucked in, and then the second scroll onto the pupillary margin. It is very simple. Drag it and drop it. Again, drag and drop it. And then you center the ring centrally so that you get a very good rhexis in the center, which is very important in case of a premium lenses, where the center of the rhexis is very important. You complete the rhexis in the usual manner, whichever size you want. And after the nucleus is removed and the cortex is aspirated, which you can do it very well because visualization is good. The intraocular lens is implanted in the bag, after which the anterior chamber is again reformed with the viscoelastic, and then using a Sinski hook, disengage the rings one after the other, and use a second instrument to support the ring, pull it out with the McPherson's forceps. The second case is again, this was again a shallow anterior chamber, patient on tamsulosin, IFIS, and near mature cataract. So you can see the fluttering of the iris. I stained that because it's a near mature. So this is how you load the Guptha ring. And it's not necessary that you have to get all the rings kind of engaged in the first attempt itself. You can put the ring entirely into the anterior chamber and then start kind of holding it. And this case, it was very difficult because the iris was very floppy. So, but I managed to get the all these scrolls in position. And here you're getting a square-shaped opening. The first one was a diamond-shaped. So whichever you want, you can kind of arrange it, depending on the amount of exposure you want. And it's easy to introduce this even in the middle of the surgery when you have a small pupil. So again, lens is introduced and it's disengaged one after the other. Put in some more OVD to stabilize the anterior chamber. Use a second instrument to support the ring and pull it out with the McPherson's forceps. So this is my last slide. So Guptha ring is made up of a polypropylene monofilament. It's similar to that of a Malyugin ring in structure. It's got 4 scrolls, but the size and the scroll size is also smaller and thinner than the Malyugin ring. The good thing about this is it's got 2 planes. The 2 limbs lie above the iris plane, the 2 limbs lie below the iris plane, and you get a dilatation easily about 6 mm, either square or diamond. And loading is also very easy. It easily passes through the 2.4 millimeter to 2.2 millimeter incision. Thank you.
How does the pupil look like? I mean, we have been using a lot of BAXs. I think Minu and a lot of BAXs.
This doesn't distort the pupil much. It's almost just the sphincter, small sphincter tears will be there
in any device.
But otherwise, the pupil is almost, some cases, it is almost the normal size after the surgery is over, post-operative.
If it's a very, very small pupil, this Guptha ring or Malyugin will not work. Even the BX does not work. Even Suvan, what he says is, you should stretch the pupil and then use the BX, which I don't do, because if you stretch the pupil, you don't have any control over that. It may become atonic,
still iris hooks are the
iris hooks are the best. Yeah. But Guptha ring, I've been using Guptha ring also. When compared to Malyugin ring, it's more rigid. Yeah, otherwise it's a fantastic.
But it's cost effective, sir, because you can up to 3 times you can sterilize it and use it. So which the net cost becomes very less.
Trinity eye care cost is not a problem, I suppose.
So in IFIS or small pupil, when I do toric lenses, it's important to have, even if it's a mid-dilated, I use expansion device so that I can see the alignment marks. So in that cases, I aspirate all the viscoelastic from underneath the bag, underneath the IOL, and from the anterior chamber partly, and then stabilize the lens in the bag and in the axis. And then I put in some more of sodium hyaluronate into the anterior chamber alone, and then take out the ring. Because after implanting the IOL, if I take out the ring, I will not see the marks, and also the pupil will be very floppy, and I won't be sure I'm taking out all the visco out. And so this is one thing I'm doing differently in this.
Thank you.
What is the, like, you may have used BX also, no?
I have used BX also.
So which one you feel is easier?
I feel this is better.
Gupta is better?
Not because of the initially, probably the initial stages only I used to use BHEX because the engaging was little difficult with the forceps and all that. This, it's easy, whatever instrument, you don't need an extra forceps or anything. With the Sinski hook, you can just engage it. So I find this is
better.
even more, and since I've been using it regularly, I think I'm very comfortable with this.
Definitely the trauma is definitely more with a Gupta ring compared to BX. BX for Phaco, an expert Phaco surgeon, I think a BX ring, regular BX ring is adequate enough. And it produces less of trauma. And removal, I think you have to be very careful while you are taking out the BX ring. When you are taking it out, you press down the iris a bit and then take out, so that from underneath the iris pigment epithelium is not peeled off. That is the most important point. And I feel the trauma will be less, chances of hyphema and all those things when the one end goes and hits. Because when you stretch and put in a larger ring, there is always some amount of stretch at the iris root. That is what my take is. So I have stopped using.
Any iris root bleed or something you have noticed? That last part when you put?
No.
Because once or twice when I tried, then you don't, there was a small oozing from that.
That is when you introduce it, the leading scroll, sometimes if you don't really check it, it will go and hit the iris root. But that is why I'm telling you, when you're introducing itself, you get the first scroll onto the, engaged into the iris, so that the rest of the thing will not happen.
Even with malignant ring also, the same hyphema can happen, ankle bleed can happen. I have seen videos of malignant ring being inserted with massive hyphema, bleeding on the table.
So this is because it's trailing, the last scroll, being pulled maximally to one side.
Correct.
If we do the way I do, you retract the iris on that side and minimally pull, this will not happen. That will not hit the ankle.
Basically, I use a Coughlin's hook to retract the iris, to put it inside.
No, when you're using a trifocal or EDOF lens, if you want to, I would suggest that you use BX or Maligan, because they don't distort the pupil as much. But when you're using iris hooks, if you're going to use only iris hooks for this, only thing is make sure that you don't have too much of traction for too long a time. If you have too much of traction for too long a time, what will happen is certain amount of sphincter rupture will be there, sphincter tear will be there, and it can distort the pupil, which is going to matter in a trifocal or a EDOF lens. Pupil size is very important for these patients.
Iris hook actually is very good. The only thing is, please do not stretch to the limbus. That is what we should always remember. We need only about 5.5 or 6 mm to do your exercise and do your emulsification.
Also, what you do is, once you remove the nucleus, you don't require much of a pupil dilatation. So you relax. What I do is, I just relax the iris hooks a little. Relax it so that it's not stretched too much. So it doesn't distort the pupil.
Another thing I just want to tell is that when you're introducing it in the middle of the surgery, when the pupil is constricted and you're introducing it, you have to be careful when you engage the scroll, because you should not engage the capsular margin also.
And another thing is, like, when you remove it, when you remove the hook, I think you should not directly pull it out.
No, you should not.
You should detach the hub and then push the hook inside, turn it and remove it. Because when you, most of the time they show that you can just remove it out easily. That is what the company people also say. But then that damages the sphincter. I use only hooks. I don't use any of these rings, and quite happy with that.